Hello, everyone, and welcome to our monthly Integrative Psychiatry Zoom meetings. I am delighted to introduce Dr. Blake Gibson today, who will be speaking on FIRS, Fetal Inflammatory Response Syndrome, and risk of psychiatric disease. Dr. Gibson is a graduate of the University of Arizona College of Medicine, Tucson, initially matched into pathology, then switched to psychiatry early in his training. He did general residency in psychiatry and fellowship in child and adolescent psychiatry training and completed that at the University of Pittsburgh Medical Center, Western Psychiatric Hospital in Pennsylvania. His research interests include inflammatory and psychiatric illness overlap. He loves to play the piano and spend time with his precious wife and two little children. And he is faculty at, he'll have to remind us where he's practicing, but I will turn it over to him. And we're so delighted to learn from you, Blake.
So it's just a pleasure to be with you. And I understand from the introductions that many of you are in private practice. And while it may not seem like a research talk on placental inflammation may apply to you, I hope if I do a good job today to make the case for why it even applies in the non-academic setting and is not just an area of interest. I'd love to acknowledge my mentors, including Dr. Ranjabar, for all the help in getting me to where I am today, and couldn't have done it without you. So many of the learning objectives today center around understanding the link of inflammation and psychiatric disease, which is no news to anyone here today. FIRS is maybe an unknown entity to you, so we might talk a little bit about that and then kind of share with you the retrospective data that we found and what its prospective implications are. So to just spend a minute on the environment and psychiatric disease, it's complicated, right? Stress and nutrition, intrauterine exposures, all of these things can sort of be a risk factor or driver of psychiatric disease in kids. And same with genetics, right? While there is no one gene for any psychiatric disease, there is some implicated risk, right? We know that many of our disorders in psychiatry have a hereditary risk factor, and we know that even from adoption studies, right? Children whose parents maybe die from suicide, have an increased risk even in an adoptive setting. And what makes it even more complicated is these gene contributions tend to overlap. Have you ever had a patient that their diagnosis list is like schizophrenia, bipolar, ADHD, ODD, and you're thinking to yourself, how in the world could someone have all these things, right? And the truth is that sometimes these phenotypes of the DSM are shared common neurobiology, right? We've parsed this out in the DSM as a phenotypic phenomenologic characteristic, but on a genetic level, some of these disorders are really quite common in their overlap. So inflammation and psychiatric disease is tightly linked. Now, I was a pathologist there for a few years, so I'm going to put up a diagram from Robbins for those who had to see Robbins and Cotran during their medical school. I don't mean to give you flashbacks here, but there's a lot of things involved in acute inflammation with, like, say, a cut. And I want you to pay special attention to interleukins and TNF, right? These are implicated in how the leukocytes, or these white blood cells, kind of activate and recruit to somewhere. And you might remember that acute inflammation can lead to chronic inflammation, and that there's different things that sort of are implicated in one or both or sort of more than one side of it, right? And there's a gas pedal and there's a brake. So IL-10 maybe puts the brake on an immunoinflammatory response, where IL-1 or 12 kind of puts on the gas. So just sort of refreshing your memory that the cascade of immune response in the body has all these chemicals that kind of regulate it and make it acute or chronic. And that chronification is sometimes a problem, right? In integrative medicine, we talk about this a lot, right? Whether it's fight, flight, or flee, or freeze, or, you know, this inflammation that was kicked up and now it won't go away. Getting inflammation to be for the right amount of time is really important. And we see a lot of disorders where it just doesn't go back to where it should be. Now, the link between inflammation and psychiatry is really interesting. One of the most profound cases I can remember from medical training was interferon for hepatitis C. If any of you trained a few years ago when this was more common before the newer agents, 40% of people with interferon treatment would get such a wicked burden of inflammation. They would be so depressed, suicidally so in many cases, or interleukin 2 treatment for renal cell carcinoma. I remember when I was in medical school in Tucson, people do this treatment because there was a chance of curing their metastatic renal cell, but it was the most punishing thing you've ever seen. And by day 4 or 5, patients were in puddles of tears from the depression that had come on as a result of this inflammation. And we know from other studies that this inflammation is implicated in all sorts of things: suicidal behavior, ADHD, schizophrenia. There's a common denominator here, though: IL-6, interleukin 6. And this diagram sort of pictorially represents all the different psychiatric disorders that have their implications in IL-6. It's really striking, right? This acute inflammatory response. You take a bunch of kids with ADHD and just sort of see what their IL-6 levels are at baseline, much higher than controlled children. And so IL-6 keeps coming up in the literature, right? Whether it's externalizing symptoms, whether it seems to affect different male or female sexes differently, it just kind of keeps coming up. So, real quick, let's just talk about the placenta, because I think as psychiatrists or mental health professionals, we don't spend a lot of time thinking about the placenta. What does it do? Well, a lot of stuff. It's kind of the forgotten organ for years, the last 100 years. The placenta mostly went in the trash after birth, and the medical community didn't really think much of it. And now we know how wrong we've been to do that. It's an amazing organ with amazing function. It's not just feeding the baby. It's an immunologic barrier. It's an endocrine thing. It contributes to the neural development of the fetus. I mean, it is an amazing, amazing organ on a cellular level. And there's a window of opportunity by which the baby grows and interacts with its environment, right? In the first couple trimesters, genetics drives a lot of this. Not to say that the environment couldn't affect the baby, but by the third trimester, the environment, more than just the genetics, are really driving the development. And this connects back to why males seem to be more susceptible to some intrauterine insults than others, or why in the Danish study after World War II with the famine that happened in those days and the increase in schizophrenia of the children of those mothers, right? The famine and the stress of that nutritional deficiency and psychological stress of starvation led to a huge increase in schizophrenia. And it was timed to second, mainly a little bit third trimester. So the placenta looks like this. And there's a fetal side and there's a maternal side. So what is FIRS? Well, it's like SIRS, systemic inflammatory response syndrome, except for the fetus. And the definition is, here it is again, IL-6 elevation, right? The hallmark way to diagnose FIRS is to sample the cord blood and see that the IL-6 is above a certain point. Now, there's a little asterisk here. In recent studies in Japan, premature kids, like we're talking 26 weeks or earlier, had really, really high IL-6 levels and probably not FIRS. So extreme prematurity may be a complicating factor here, but for now, let's just say, a fairly full-term, somewhat premature baby, IL-6 up means FIRS. You can also see in the histology of the placenta, so if there was intrauterine growth restriction or there was concerns about intrapartum substance use, or the different institutions have different reasons for looking at the placenta under the microscope with the pathologist. But if the pathologist sees phenocitis or chorionic vasculitis, that's also a way to diagnose FIRS, because clinically we don't really take cord blood except for research purposes. So for you private practitioners out there, if you have patients and you can get their placenta report, which many of them may have in some long forgotten corner of a medical record, you could see, what might be in the report that might say, oh, you were born with this entity. Phenocitis is inflammation of the cord. So it's that fetal side of things. Maternal inflammation would be chorio. This is fetal. Again, fetal inflammatory response. And you can see this under the microscope. Various things can do it. Maternal autoimmune disease, Listeria, Candida, prolonged birth. Chorionic vasculitis is a vasculitis, an inflammation of the blood vessels in the cord. So again, the fetal side of it. So FIRS, again, rarely occurs before 20 weeks. It really starts to occur in that second, third trimester, and it's extremely common in preterm births, extremely common. Duration of labor, if I didn't mention it, cytomegalovirus, PPROM and PROM. So, a lot of women out there with otherwise normal pregnancies, end up giving birth to a kid, maybe 38 weeks, 39 weeks, So most obstetricians would not say that was, anything to write home about, but they very well could have had FIRS in there. And it takes a little bit of intentionality to sort of, when looking back, see if that was the case. FIRS prior to our study was known to have some cerebral palsy implications, a ton of implications in the spleen or the thyroid, and the obstetricians and the pediatricians have been paying attention to FIRS longer, but no one had really linked it to really clear psychiatric problems before our study. And just to bring home the point that kids with FIRS are born with a different genetic load, look at this diagram. The FIRS people are clearly having more genes turned on, more genes decrease, hundreds, than no FIRS people. So back to that initial part of my presentation, the genetic load of FIRS people is different. We see different health outcomes with different organs, and we see a different genome. And if you Google some of these existing known loci that have changed with FIRS, you're going to see they co-locate to a lot of psychiatric disease, which is going to lead me into telling you about our prospective study here in a moment. Okay, so what did we do? In the last 20 years, we looked at 4,000 some kids born to the Women and Children's Hospital in Pittsburgh and a bunch of controls. And we said, did they get psychiatric disease in childhood? They did. PTSD, conduct disorder, autism, ADHD, and any psychiatric diagnosis will be very strongly correlated with independently having FIRS in regression models. Which makes sense, right? This super inflammatory event that can last for hours to days to weeks, different than prematurity, independent from prematurity, but probably leads to prematurity, changes genes and sets you up with a different risk factor. And I know conduct disorder may seem to you to be entirely environmental, but it's really not, right? Whether it's the MAO gene mutation or skin conductance or heart rate variability, right? There is a genetic propensity of some people, some families, to have more rule law violation, more incarceration. I mean, it's complicated with systemic racism, certainly, but I think neurobiologically, I can stand on 2 feet and say, conduct disorder does have genetic underpinnings beyond just environmental trigger of trauma or abuse or neglect. And when we kind of start to run the data more, this signal is maintained and the hazard ratio is really quite elevated. So here's a money shot diagram, right? A cumulative hazard estimate of FIRS versus controls for autism. Huge signal of risk. And a risk right around the time we would expect to see it, right? Kind of in that early developmental period. And if we control for follow-up, right? Well, Blake, what if people left Pittsburgh, right, and moved out or went to the Allegheny Health Network and you didn't see their records anymore? Okay, good point. Well, let's say, okay, they had at least many years of follow-up in our system. Did we still see these results? And while bipolar did lose significance, conduct, PTSD, autism, ADHD, all retained significance. No matter how we tortured the data, we kept seeing this signal, which was really interesting. So, of course, there's limitations. This was a retrospective study. I wasn't able to have paternal data. Maternal records are linked to the baby, so I could query mom's disorders psychiatrically and control for that, but I couldn't control for dad's. It's unfortunately a hiccup in how we keep records and who they're associated with. Um, I didn't have 10 years of follow-up in a lot of people. A lot of it really was closer to 5 years. So what would have happened if we had 10 years? Well, that may actually support the findings of our study because the signal was so strong. The more time we would have had, the more we probably would have seen even more diagnoses come up, right? Psychiatric definitions changed during this time period. We went from DSM-4 to 5, so that means we were less parsimonious about who got an autism diagnosis, where we were more parsimonious 20 years ago as to who got Asperger's versus autism. Again, that kind of helps our study findings, though, right? Even with more generalized, less specific, more sensitive criteria, we still saw the signal in spades. Some medicines have anti-inflammatory properties and anti-infection. So if a mom got rifampin, during the concern for infection that may have led to FIRS, we could have confounded things a little bit and weren't quite able to control for that. Not all placentas are examined. I don't know where you did training or where you currently work, how their policy is for examining placentas, but in Pittsburgh, there's a list of, concerns during pregnancy, no prenatal care, whatever, and we'll send it to pathology. Or if it looks funny when we look at it with our naked eye. But what if we missed a bunch of, normal placentas that weren't examined? Well, when they actually did a study on this and looked at all these placentas that were supposed to be normal, FIRS was only in 6%. So we're probably not missing a bunch of FIRS by ignoring the normal placentas. But the rate is probably there a little bit. Not every pathologist is looking at phenocitis or chorionic vasculitis. It's not necessarily something, especially in the community, all the pathologists are always looking for. So what does this mean? Inflammation in fetal inflammatory response syndrome may change your genes, may set you up for more psychiatric disease. So what do we do about it? Well, maybe a lot. There's actually trials undergoing right now to treat FIRS, not for the worry of psychiatric reasons, but for the bronchodysplasia or the other organ system implications using IL-6 inhibitors during pregnancy, or even more up higher in the cascade, IL-1 or corticosteroid blockers. And so some studies are now looking at, can we monitor daily vaginal IL-6 after PPROM to see if FIRS has developed and we need to deliver the baby and prevent these negative health outcomes. What really excites me as a psychiatrist, though, is that with this research, maybe I could be consulted intrauterine as a child psychiatrist to help prevent the emergence of psychiatric disease in kids. Man, that would be cool, right? Talk about early intervention. Like when I see a kid who's attempted suicide at 16, we're 16 years too late, right? That's been a long time that they have maybe suffered months, years before that suicide attempt. What if we could get in there intrauterine and prevent some risk or have an early detection clinic? Hey, you were born with FIRS. I see that this happened when you were a baby. I'm going to keep a little closer eye on you. We're going to check in a little more often, as opposed to waiting till your first suicide attempt to see psychiatry or therapy. I love this diagram. This is why I'm a child psychiatrist, right? Our ability to change is so much greater the younger we are. And I guess when you get older, it's all over. No, I'm kidding. No, that's not true. But um, I just love the plasticity that we're working with in child psychiatry. So I've got a grant from WVU to do a prospective trial on this. So we're currently through the process of recruiting children age 6 to 10 born with or without FIRS and collecting their genetics and their IL-6 levels to sort of see, hey, is there that differential gene expression we're expecting? Are there a different morphology, pathophysiology of their psychiatric disease, and what differences can we see in that?